Well, TJ's behind me typing so that he types so fast it sounds like tap dancing or something. And I said flashes.
Hello, Sylvia and Lori, who are apparently here but not talking to us.
Yeah.
10 seconds. I don't know what I'm doing in my
I'm
hand.
here.
Oh, there you are. Cool. Okay, in 5. I guess I can start it here, huh? Start. All right, as everybody comes in, here we are. And why does it say September up there?
Well, it says attendees are still on hold on my screen.
That's good because you got the wrong slide deck up. I know that because it says September.
Oh my gosh.
I didn't even notice that this whole time.
I know, we've been chatting. Well, you're live on YouTube and other things, so I guess I may as well.
The broadcast is now starting. All attendees are in listen-only mode.
You sure it's not the right one?
How about, yeah, we're not in September, and I know that.
But I got it from the file.
Okay, we will switch to the other screen, which is Boyd.
Boyd's driving.
I don't know which one it is.
I was so excited that because that's the one that's in the file.
Okay, well, let's see. How can I say this? Let's go to the secondary screen.
You know what? Everybody
you're live, so just introduce yourselves and say hello while I get this.
I was going to say, Boyd, everybody should see Boyd's office because it's like NASA in there. He's got In fact, one night we were counting how many screens everybody had. So welcome, everybody. It's not September. It is November. It is our Q&A public webinar. And guess what? The exciting thing is we have 6 great topics to share with you. You know how if you were usually visiting us at these monthly Q&A webinars, you know that we like to tell you everybody has graduated and passed their exams. We have 8 pages, 8 slides today, not pages, but slides.
We are rocking, as they say.
Yeah, I'm going to, did I stop sharing my screen? Am I good?
You did. Yeah, you're on my computer right now, and I'll give you control here in a second. I'll run it.
You just run it.
Yeah, how about that?
So if you guys can all hear us and see us, make sure you put that 1 and 2 in the chat for us so that we know that everything on your end is working well. It may appear that we don't know what we're doing, but we do. We've been doing this
on your
for
toes.
Like 8
That's what
years.
we're doing. Yeah. Keeping you on your toes.
We know each other. We just yak and don't even pay attention to what's going on.
Well, Boyd is very good about telling us, 5 minutes, 2 minutes.
I had a backup plan, so I was ready.
Yes, he was.
He said that like 10 minutes in. He goes, I have it on my other screen over here. He didn't know which screen it was.
She really didn't want to do that. Anyway, so thank you for being here, everybody. If this is your first time, we're going to hear from you in a second to find out who's on the webinar and such. And as always, some of you have been here a long time, so welcome once again. General webinar that you're seeing on the screen are about all things business certification and medical coding, billing, and practice management related here at CCO.US with my 2 wonderful co-hosts here in November 2019, Jennifer and Alicia, with your respective credentials at the AAPC shrine, if you will, given to them, if you will, right?
Yeah.
We like that, right?
Yeah.
That's cool.
And a little bit of housekeeping. We cannot hear you if this is your first time. You can always ask a question in the chat. Our team behind the scenes will always be working on and trying to answer those as we go along. Some of them will be reserved for the end as well. And we're also going to encourage you to stay to the end to get a free giveaway, as we always do during our webinars. So, first poll: how many CCO webinars have you attended? Let's find out. And let's find out where I'm going to start this poll from. Let's see.
You know what? This is fun because, like I mentioned, Boyd and I have been doing this for over 8 years now. And when we started doing these polls, that was fun. We try to change them up. Boyd comes up with a good idea or something that he thinks will be beneficial for us to know about. So some of them we are consistent with, and others are new. This one, is it your first time? Woot woot. Are you back for more? 1. Are you a repeat offender? 2 to 5. If you're liking it here at CCO, 5 to 10. And if you're a frequent flyer, you've gone to over 10 of our webinars. Now, we don't mean just our Q&A webinars. Maybe you catch us on those other webinars too.
Well, that's a good point. Yeah, that's a good point. And if you're on Facebook or YouTube at this point, you can type in the chat there and we can get your response. Unfortunately, you cannot actually participate in this unless you're in GoToWebinar and registered and such, nor can you win our prize without logging into GoToWebinar. So you can always jump over to cco.us and jump in and register and maybe have a chance of winning one of the prizes here you'll hear about in a second. So
That's
I think
right.
we're good. I can see the responses are pretty much at 83%, so I think we're good. We're going to close that and let's share the result. I think that we are pretty good here. We've got a lot of first timers, 43%. Back for more, that's 1 is 6%, 2 to 5, 7%, 5 to 10, 16%, and frequent flyers, 10 plus, 28%. Wow. Awesome.
I don't think I've ever seen 43% of first time. So
I don't think so either.
that's
Yeah,
amazing.
great.
If you are watching us on LinkedIn, you couldn't do the poll again, but know that they're new to live streaming, and we're really enjoying that area, meeting the people in the in LinkedIn. It's been fun.
Well said. All right. So as I go too far, we're going to talk to a little bit about the agenda here. So we have this, kind of recent upgrades, new CCO news, and also recent graduates. So we're going to talk about those to first up right after this. And then we're going to take your questions that have been prepared by Alicia and also Jennifer. Jennifer, as always, tell us what you're going to be talking about today.
Oh,
Yeah,
can't hear you.
Please.
I muted it so you couldn't hear my son. Sorry.
Oh, there you go. Smart.
So we had a question come in about ADA testing and how does that occur? How does that take place? And we have a fishhook removal in the ER, which surprisingly happens quite often from what I seem to find out. And coding by artificial intelligence, is that going to be a wave of the future? So
we're on top of it, the future, aren't we? I get to talk about cardiac catheterizations in nuclear medicine. Had a great question come in about that. Vascular surgery coding, again, another great question, and it's a little bit different than other types of coding, heart and cardio. And then someone had asked about diagnosis coding for healing wounds, and as you know, I love diagnosis, and so I grabbed that one. We'll be talking about that today.
Awesome. Thank you, ladies, for taking the time out to prepare those for everybody. That will be shared in years to come. So it's always great to see the output on YouTube, and we'll talk a little bit about that later as well.
Might be a good time to plug that those are questions that came in from you guys. So you submit the questions in a topic request, and then we do the research them for you. So feel free. We'll tell you by the time the webinar is over how you can put in your requests.
Yeah, you can actually see it right on the screen right now. So in the blue there, it says cco.us/topic request. We're prepared for your questions any particular time. We always like sending people there because then we can prepare them like this and do a better job at it rather than just answering something quick on Facebook or YouTube or whatever. But really, because what billing question or coding question is a one-sentence answer? I don't know too many, right? Probably not very many at all.
No.
Yeah, but anyway, during the webinar, because of the 43% of you who are first timers, you can ask a question again anytime. If it's long and takes a long time to prepare, then we probably won't answer it at the end. But if it's something short that we can answer or help you with or send you a link to maybe get some more education, we can do that along the way with our team in the back who's very educated on these and has done a lot of these with us along the way. We also have Lori and sorry, who else do we have in the back? Sylvia,
yes.
sorry, Sylvia. So they're going to be taking your chat questions and preparing them for hopefully wherever they got to go. So they're managing that cattle run, if you will. That kind of background. All right. So any questions about that? Drawing in the end. Yeah, we're going to find out who's going to be getting the giveaway that we have. Either your
The
choice
stay
of
to
a
the end.
Yep. So we got to stay to the end. It's only given out to people who are present on the webinar, a CPC review blitz bundle, or a CCO club membership. So, or you can also get a call with Alicia or one people on the team. So if you're needing some more extra one-on-one help, I personally would take the coaching if it was me, but maybe it's
I
different.
take the 1 year of CCO club.
There you go. Right. If you're stuck,
That's true.
yeah, getting expert advice is always a good idea.
Mhm.
And we are talking also about the CCO club. So during the webinar, we're going to be talking about pretty much our flagship product, which is a CCO club, available at cco.us/club. And this is a place where you can get up to 80 CEUs, which also includes our webinar and support call replays, billing and coding Q&As, and extended product support. So we're going to probably take a poll a little bit later, and you can see how popular it is for people that are attending this webinar and the value that they get out of it. And a lot of the people who are giving us testimonials are also in the club as well.
Yeah.
Cool.
Yes.
So what is your status right now? Next poll. What is your status as a medical coding, billing, or a similar medical business related job? And if we wait for Boyd to hit the button, there's your opportunity to do that. So are you looking? Go ahead.
Okay,
Yep.
looking at a medical career as a coder, are you certified and looking for a job? Are you employed? Improve my current job situation and earn a new credential? No, not pursuing employment at this time because I'm independently wealthy. No, that was just added on there.
And if you won the lottery
They knew those lotto numbers. Yeah.
Uh,
One of the 40% of people who win the lotto based off their Chinese fortune cookie numbers, right?
I read an article one time, they investigated those because a whole bunch of people won, and they said, so they figured that it was kind of in a regional area, and they thought that somebody had, done some fraud, and come to find out all these people had played the Chinese numbers on the fortune cookie, and that's why they all won.
It's about, I think they've done it. It's about 40% of people who win the lotto got their numbers off of Chinese fortune cookies.
It's just crazy.
So here are our results there, Alicia. Go ahead.
Oh, wow. 37% of you are looking for a career in coding. Then you've come to the right place. Certified and looking for a job, we have 11%. 23% are employed. We have 27% are thinking about earning a new credential. And 3% of you, only 3% of you, are not pursuing employment at this time. So we want to get to know you better.
Well, if I could answer, that would be me, I guess.
That's
Am I not
right.
pursuing?
Not
Yeah.
pursuing.
Yeah. People who are happy in their job. That's good to know. So
Yes.
Awesome. Okay, so who are these people?
Wow, this is fun.
Graduate.
Sometimes we get a lot of people. It kind of runs in droves, but let me just give you a heads up. This time of year, more people are testing because they want to hurry up and test before the end of the year. They don't have to buy new manuals and any changes that are going on. So from here on out till the end of the year, you're going to see lots of names. And therefore, I think we have 8 slides of names of people who have let us know that they recently passed one of the credentials, and Jennifer graciously said that she would start out for the first page.
So we have, these are all CPCs, Deborah Speller and Rowena Kumar, Garland Paul, and Christy Goss all used different types of techniques that are offered, especially the BAT technique looks like everybody used, and they passed in September. So
Fabulous. Veronica Ramirez. We have Pamela L. and Althea. Oh, Frimpong?
Mm-hmm.
I thought my glasses would help, but they didn't. It's too far away. They all used the BAT technique. Great. The BAT system for the CPC.
Third.
More CPCs. We have Pam Sundstrom, Crystal Forbes, and Kathleen P. passing their CPC, mainly using the BAT techniques and the blitzes. So catching up those refreshers. Yeah.
Or
Sunny S, Susan S, Jennifer O, and Christina Slayton, CPCs. Man, look at those bats.
We have Naomi Savage, Jessica S, Jazreen Singh, and Sylvia Renee Simmons, all CPCs just recently within this past month, it looks like. So great.
Christina A, Lori Spotted Horse, and Gina Elias, not sure, Alias. All CPCs using the BAT as well.
my native name is Boyd Bald Eagle, just so we kind of keep that in perspective. I love Spotted Horse. That's great to me.
I like that name too.
We have a spattling of different exams here. Catherine DeWitt was the CPC. Therese Antonio was a COC, outpatient. Leslie Johnson, CRC, risk adjustment. And Anna M, a PCO. Is that CPT?
Compliance.
Compliance?
It's supposed
Okay.
to be a CCO, I think.
Okay, yeah.
Yeah,
And I think
practice
that's the last one, yeah.
Yeah, Brandon Dumleo, Dumleo, the CCC, that's a cardiology one. That's fabulous. Sarah Otto, the CPB, which is billing, and so did Erica Voigt, did the CPB, which is Jennifer's thing, the billing. That's great. Oh, little heads up, guys, if you get the December AAPC's magazine,
Wait, hold that thought. Hold that thought. We're talking about
for that.
Yeah, we have a
never
slide for that. Yeah.
Okay,
We have
never mind.
We have some
Surprise.
And
All
in
that
fact, we just got a comment in YouTube that's asking, what is the BAT system? So just hang on and we're going to answer that here in a couple seconds about what that looks like. So now we're on to the prepared questions, and I believe Alicia's going to start us off. So these are the prepared questions that we've taken the time to prepare them for you guys. And the first one from Alicia, as we drop our cameras off, is going to be about, actually, I think I went too far. There we go. Nuclear medicine and cardiac catheterizations.
Yes, the question came in, said, can you clarify the basics for using 92920 through 92944? I think it's the term nuclear medicine that is confusing me. How is the medicine codes related to cath codes? As the answer sheet's coming up, I want you guys to know an excellent resource for cardiac catheterizations is Z Health Publishing, and I got some information from them for this, so I'd urge you to check that out. The first thing I did was I grabbed a picture of what a nuclear medicine image looks like. So let's understand the nuclear medicine component of doing catheterizations. As you see here, nuclear medicine is injecting like an isotope into the body through the blood, and then imaging. Sometimes they'll do before and after images. And we can see that the top line of those images is the vessel or organ at rest. And then the bottom row is actually it working. Okay. So when you're doing actually watching the organ do its job, it changes the imaging. Another thing that I wanted to make sure that you understand, and man, I used a lot of pictures this time, is that what they do is they inject, or you can swallow. You've got to get it into the body, the isotope, or if they're doing some type of it's not a barium enema, but you can go both ways. Sometimes they just put it in like sugar water that goes through the vein, when you're doing a PET scan. But this is where they'll put the tracer, or what I call the isotope. I don't know if that's the actual term. And then they will monitor the patient, and they will put you in what kind of feels like a big MRI machine, but it's not. It's actually a gamma camera. And then there's another, and you can go get these off Google Images. You see what to expect during a nuclear stress test. And I can tell you that if your provider does caths, the cardiologist, that the nuclear stress tests are kind of the bread and butter for what they do. They are a less invasive way to be able to go in and find out what's going on with the heart. And again, what you do is they have you, they monitor you at rest, they monitor you at working the body up like a cardio physical type thing, and then they inject you and then they scan you. Now we can slide down. Let's get into actually what it means to do these nuclear tests. And nuclear medicine really just means that we're putting a type of radiation into the body. Okay, but it's not even as much radiation as you would get with an X-ray. Okay, it's less than that. I think I was told by the nuclear medicine guy that the CT scan, you get more. That's the most radiation you get. But the nuclear medicine, what these guys do, and these stress tests and stuff, it's not even hardly anything less than an X-ray. You can scroll down, Boyd, just a little bit, and the next slide will have more information about the gamma camera, and you works on visualizing an organ. So we can do an organ at rest, and we can do when it's actually working. Several reasons why they would do organ tests. They do kidneys, they do brains. For my son had one, and it was for his brain and seizures. But for catheterizations for cardiology, what they're doing is they're again wanting to image the heart. Where is the problem in the heart that we need to go in and put a cath in, and maybe put a stent, or maybe we're going to have to identify where possibly we have a blockage and we're going to need to do a bypass or something. So by them doing this camera with this isotope, or whatever we want to call it, I just like calling it isotope, then it will show them in a very non-invasive way where damage is being done, so that they can pinpoint it and then go in and go straight to the problem and not have to be looking around to find out where the problem is. So again, it's less invasive. A lot of times they'll do a cardiology ultrasound first. They can see that, okay, the heart's not working properly, we do have a problem. Then they'll do the nuclear medicine imaging and be able to say, okay, here it is right here, and we can take that mammary because of where it's at. We'll be able to go ahead and take the mammary artery over because it's on that type of the heart, or we're going to definitely going to have to take a saphenous vein on the other side. So it's not necessarily the first thing that they do. A lot of times they'll do the ultrasound first, then they'll do the nuclear medicine imaging, and then they'll go in and do the cath. Just to go over some codes that you need to be aware of, if they're doing coronary artery angioplasty and atherectomy or stent placement, then you're going to see these codes, the 92920, and notice how that's like a parent code. And then for additional branches that they're going off of, because they'll fork, you know, and then those are all add-on codes, except for 92924. See how they have an add-on code with each one of those parent codes. So are we doing an angioplasty? Are we doing an atherectomy? Are we doing stent placement? Okay. And then if we scroll down, we'll see also some codes that you need to be aware of for not only do they do the stents and stuff, graft, vascularization, and then they'll talk about just doing a single vessel, or if they're going to do each additional branch. So again, you see those parent codes, the 92937. Then we have a revascularizations of an acute total or sub total occlusion during an MI with a single vessel. and then revascularization of a CTO. Okay, and we've got the native coronary artery, which means the artery that hasn't been tampered with, we haven't done anything to it, bypassed it, branch, or a bypass graft, one that's already been grafted. And then we have the same thing, the 92944 plus the C9608. Revascularization codes are listed there for you. And I wanted to last show you why it's so important to be able to have that option of the nuclear medicine. When you look at the imaging of the heart, the vascular system of the heart, again, when they do a cath, a lot of times they'll go up in through the femoral artery that's at the groin. See, they send that wire all the way up into the heart. Okay. And then look at the tiny vessels that branch out. And remember, we kept saying, you know, each additional branch, that means it branches off. It forks in the road. We got to decide, we're going to go left, we're going to go right. But they don't have to spend a lot of time deciding where to go when they've done the nuclear medicine imaging, and then they have pinpointed right where the problem is and can go directly there, take care of the problem, and then get out quickly. Now, that is just a tip of what nuclear medicine does. It's quite an exciting area that we have in medicine, and I hope to bring you a really cool nuclear medicine webinar in the near future. I've been working on that, and all of this stuff will be in there and so much more. So thank you for asking this question.
Awesome. Thank you very, very much.
You can tell I like this stuff, right?
Yeah, I can. I can. And I think we've got another poll after this. Let's take a look. And let's see. Oh, no, this is our fun stuff. So what happened here with all this? We had a bunch of chat stuff happen today in our messaging platform.
Oh, yeah.
And this is what it was all about. What's going on here, guys?
Well, if you are part of the AAPC, now some of you who are first-time attenders here and are looking to get certified may not be members of the AAPC. That's one of the many credentialing organizations. There's a FEMA, there's AMBA, there's PAYCOM, there's several out there. However, the AAPC has a magazine called Healthcare Business Monthly, and as a member, we get one sent to us, but you can go online. And Megan Wilford was talking about the tips for testing, what you need to do. And she mentioned Laureen, which is so exciting, and the BAT technique. So this is the article. We couldn't blow it up really large for you to be able to see it. We played with it for quite a while trying to do that. But excellent information that Megan gave us. And here's a little excerpt of tip number 4. Don't be afraid to mark up your books. And that's what the BAT technique is all about. The CPT manual, we've all done it. We do it every year, and it's updated every year. It's not something that you copy directly. It's a technique you learn to be able to duplicate it year after year. You kind of make it your own after you've done this for a while. And there's an example of 28200, how you would highlight the information on that code that you want to pop out at you that makes it different from 98202. So again, thank you, Megan, for mentioning Laureen and the CCO.US and the BAT technique.
Well, it's interesting too. You know, you mentioned you do this every year, and people are probably thinking, I have to get certified every year or something like it. No, once you're certified, this technique just helps you now that you're in the business field. You know, now that you're doing this every day, you still need to be able to quickly grab codes and quickly assess the information. So if you spend the amount of time that's required at the beginning of every year going through this in your books, it helps you in your daily job as well, not just testing. So I mean, you know, I don't want you to think that you have to test every year.
It makes you code to a higher specificity. It makes you more accurate. And as a coder, it's quality and quantity, but we want quality, but we all do it's production. So we want to be fast, and so it's just a way to it makes you faster because you can grab those codes because you see the highlighted area. Your eyes aren't wandering all over the page. And it teaches you to make notes off to the side to codes that are applicable to your daily use if you're coding ENT or cardiology and stuff like that.
Nice. We also talk a little bit later about the CCO proven process. And our process, it kind of reminded me when I was looking at this morning about what our process is, but we'll talk about that a little bit later too. But I thought this was a great article, just looking through it based on what I know of how we teach things here at CCO.
Yes, she nailed it. Thanks, Megan.
Yeah, well done, Megan. Cool. So I think I just want to make sure I'm in the right one. Yep, I guess we're up next with Jennifer, who's going to be talking about ADA testing accommodations.
Yep. So we had somebody present in one of the forums about if you have a disability, how can you go about taking that examination? So what are some of the requirements that they have? So at this person, they said, you know, their condition that they have, sometimes it can be difficult, especially with time tasks. So how do we get a special accommodation? So I went through both FEMA and AAPC because I know not everybody who joins these webinars are with AAPC strictly. So going through both. Now, of course, we know that the Americans with Disability Acts, the ADA, you'll hear it referred to as that, they require reasonable accommodations for not just your work, your employer, but also in cases like these testing to try and gain that skill for an employer. So anybody with physical or mental disability or impairments, they allow additional accommodations. So they say that the impairments would substantially limit a major life activity like hearing or walking, seeing. Of course, we can, you know, assume that. So the AAPC and AHEMA both do allow ADA accommodations. But of course, it has to be documented. So the AAPC listed on their website, the purpose of these certifications is we test the examinee's knowledge is what the AAPC is looking for. They want to make sure you know that content. They want to make sure you have the knowledge of the principles, accuracy, proficiency, and speed. So speed, we just talked about that. That becomes a factor. So that's why the BAT technique came out, so you can quickly pull this information. So for those reasons, AAPC considers an accommodation to time up to an additional hour. So once that exam is scheduled, then I guess I'm going a little bit out of order here, but we'll catch up. So once you've gone on and you've gone on the AAPC website and you've scheduled for your exam in the next 4 to 8 weeks, you picked a date and time that's perfect for you. So the proctors, actually, the two people who are volunteering their time, remember proctors are volunteers, they're not paid to be there. So proctors are volunteering their time to come in and sit while you take an examination. So they're going to receive information ahead of time, along with all the booklets and all the tests. And it will say you have somebody who's coming in for an ADA accommodation, and they'll let you know what that accommodation is. Because that way, those proctors can now create the atmosphere that would be required for this examinee. So do they need, you know, to have a place close to the door? Do we need to be using a room that has wheelchair access? Do we need room with additional light, perhaps? So that's something that the proctors can set up ahead of time. So those accommodations, they do allow for that 1 extra hour of testing. So that's something that actually everybody needs to keep in mind. So not just for an ADA accommodation. So if you want to go down a little bit more. So for the test takers, what do we have to keep in mind? Now, something that a lot of people don't realize when they're going in to take a test, not everybody there is taking the same test. So remember, AAPC offers a lot of certifications, and they're actually offered for different times. So an instructor certification is only for 2 hours. You have 2 hours to answer 50 questions, where the CPC, CPB, CPCO, the compliance, the billing, any of the other examinations, and all the specialty examinations. So the specialty cardiology that one of the members had passed this year, specialty orthopedics, something like that, those are all 5 hours and 40 minutes with a different amount of questions. It just depends. But not everybody's taking the same test. So some people may have different items available to them. So it's something always to keep in mind when we get up and leave, that, you know, somebody might be there longer, or if there's an ADA accommodation, we're not going to call them out, but we're just going to say that, you know, please be quiet when you leave, because not everybody takes the same test. Proctors need to be aware. So if you're offering to volunteer your time to proctor, we need to be aware that if you have an ADA test that you're helping with, you might need to be there an extra hour, so 6 hours and 40 minutes. So we need to allot our time as well. And then the examinee who has the ADA accommodation, it's always helpful. They can reach out and talk to the proctors. They're listed on the website, and they may also receive an email from them saying, you know, here's where the test is. This is what time you need to report. Please remember, bring non-noisy snacks, things like that. But to reach out to them and say, hey, where's this facility? Is it going to have what I need? I need an extra light because I have low vision. So is there an extension cord I need to bring? Or is there an outlet near some of the desks? And then maybe they're not too familiar with the site itself, but they could at least find out for you if there's anything that's going to be helpful. So the ADA accommodation examinations, they must be offered at least twice a year by every chapter. So if this is something that you need as an accommodation, it's something to keep in mind. Each chapter must offer a certain amount of exams per year, and 2 of them must be ADA certifications. We can offer more than that, but we have to have at least 2. So if there's a particular area you're in, it's rather remote, just know that there will be some offered. They have to be either in the first and the third quarter, or second and fourth quarter, but they have to be offered. To request this, how do you get to request an ADA accommodation? So a qualified healthcare professional completes a medical evaluation letter. So it could be done anytime within 12-month period. And that is going to get sent in or uploaded when you submit your application to AAPC. They review all that information, and then AAPC gets back to you and lets you know if it's been, you know, what the accommodation will be and how much extra time, up to an hour. They don't offer an on-time test, unfortunately. That's not the nature of our business. So the amount of additional time requested is up to an hour, and that includes breaks, of course. So if the accommodation is to have time of not sitting or standing or something, that's going to allow, that's going to be taken into account with your breaks. But they can make different kinds of accommodations. They can offer extra time. They can offer a different kind of answer sheet. Maybe you can't do the bubbles, the highlights. Maybe they're too small. And they can also offer a test booklet in a larger font. So in case you need to have, through poor vision perhaps, or some other accommodation, illness, you need a larger book. So if the font's too small for you. So that is all actually right on the About Us on the AAPC homepage, right on the front. If you go down About Us, there's a link for the accommodation, or there is one here. Now, AHEMA does similar. AHEMA is the other large testing corporation for coders, and they also request to submit a written submission. It can't be done by like your employer or somebody. It has to be a healthcare professional, and it needs to be a documented disability that meets their guidelines for documented disability. It should be indicate the nature of the disability and what's being requested. For what kind of accommodation are you requesting? And then again, a qualified healthcare professional must submit that documentation. So if we go down a little bit more, it'll tell us a little bit more about some of AHEMA's, what they allow. So that again, you'll be notified in writing, just like AAPC does. They'll notify you as to what you've been allowed. And then you have to submit that with the application. So they actually have guidelines available on their website, or you can contact a HEMA for their information about their guidelines. So then you complete their accommodation form, you submit the information, and then you make sure it meets those guidelines that they have. And they actually allow a little bit different, because I don't know if anybody's familiar with a HEMA versus AAPC. An AAPC exam is a paper examination. You're allowed to have your books in there. You're allowed to make all these BAT notes and all these information techniques, you know, little notations to help you remember things in your books. A HEMA's a little bit different. Theirs is in a testing facility online, and there can be nothing in your books. So there's a little bit difference here between the two organizations. So they offer a little bit different accommodations. So if we go down a little bit more, they can offer a separate testing room that might be required. Perhaps you need, because you're in a room with people taking all sorts of different, it's a testing center. So they could be taking all different kinds of employment tests in there. You could have a reader for you, an extended testing time, or screen magnification. Perhaps you don't see well on a standard sized computer monitor, so they would have some kind of magnification or zoom technology, something to allow you to see that screen a little bit more, the same as a book would be offered in a different font. So everybody does try and accommodate everything as much as possible. And so you just submit your request in and see if it can be, see if it's one that meets the requirements. But yes, we try and help everybody to succeed their best at this, at their coding career. So.
Thank you.
You're welcome.
Yay.
Wonderful.
We get asked about that a lot.
And I'm glad we actually had some people on YouTube saying that they had some challenges themselves. So you hit the topic right on the head.
Good.
Good job.
Good.
Okay, we are now talking about the special time of the year, these Black Friday sales. Well, CCO.US is not one to let that go by, to offer special deals for all of our people who are needing education. So right now through the 29th, through till Friday the 29th, we've got 40% off of our courses and review blitzes. You guys want to talk a little bit special about what those are and why they're special?
Well, you saw how many people use the BAT technique, which is part of the blitzes. So if you've had your education someplace, or maybe you're a coder and you want to sit for another exam and you think, I don't really need a whole course, I just need a little help. And that's perfect. That would really help you get over the hump and make a good score. And the AAPC lets you test twice, but you don't want to if you don't have to, right? A HEMA, you test one, and that's a lot of money to invest. But if you think, you know what, I am really enjoying this webinar, I like that they're so excited about what they do, you can tell we love coding, I want to get into that career, then absolutely pick a course. And I would suggest getting the PBC course would be a great place to start. And maybe one last tip, if say
PBC, by the way, stands for physician-based coding.
Physician-based coding, yeah, help you get the CPC or a launching point for the CCS with a HEMA. But do you see my curtain go crazy behind me?
Yeah, you got some. It's not Halloween, you know.
So the other thing I would say is maybe you want some CEUs. Our medical terminology anatomy course is a great way to pick up CEUs, and everybody needs a refresher on that. So I would suggest that would be a great place to start as well. Maybe you're certified or you're wanting to get into the medical field. Anatomy and terminology is the way to go.
I do have to say, 2 years ago, I think it was, I did buy my CPMA Blitz at a Black Friday sale. That's how I was introduced to CCO. And wait, was that before or after I met Alicia? Wait a minute, I don't know.
Oh.
I think right after I met Alicia. But I bought my CPMA Blitz because I'd already been a coder. I've already had other certifications, but I wanted auditing. So the Blitz was a very good, focused course for people with some knowledge and experience is what the Blitzes were good for. And I did pass. So it was, you know, I enjoyed the course and the content that I had. So.
Our courses come with practice exams as well. If you get the course, you get kind of everything. But if you just need a Blitz, you know, if you just really need to nail it in the test, that's the way to go. Yeah. Yeah.
Well said. Thank you, guys. All right. Alicia's now going to talk about vascular surgery coding.
Vascular coding. Another shout out to Z Health Publishing. If this is an area that you want to get involved in, I would suggest aligning with them. They have some great education, probably the #1 education in cardiology and vascular type coding. The question that came in is, I wanted to try getting into cardiology coding, and a friend told me to start with vascular surgery. I'm at a loss as to where to start to prepare for this area of coding. My background so far has only been in risk adjustment. I love it, but I want to do more. You know, we hear that a lot, and risk adjustment is a great way to start your career in coding. You can hear us talk about that on other webinars, but you know, many of you are visiting on the webinar and said you wanted to get another credential, and cardiology, like we talked about earlier with nuclear medicine stuff, that's kind of stress test, that's bread and butter, you know. And vascular surgery, let's talk about what that actually is. Let's get our verbiage correct. It really is the diagnosis and comprehensive management of anything that goes wrong with the arteries, the veins, and the lymphatic system. We don't want to forget the lymphatic system in there. Actually, the lymphatic system kind of runs along these major vessels, and they kind of bleed into each other. So it's really interesting how that works. When they say diplomats, where I got this, just replace that with, you know, your physicians. In vascular surgery should have a significant experience with all aspects of treating a patient. And it's true, vascular diseases, including diagnoses, the medical treatment, let's see, reconstructive vascular surgery, which I told you in the other with nuclear medicine, some of those codes were for reconstruction or revascularization, and endovascular techniques. A lot of this is done endoscopically, which meaning we're visualizing it as we go. You know, this is a great definition that tells us a little bit about the background knowledge that you need if you want to get into the vascular surgery arena. This was focused towards helping somebody that is thinking about this as a career in medicine, but it works with the coders as well. You need to have that. And as a risk adjustment coder, you would have the diagnoses under your belt. It's the other stuff that we need to build up your knowledge base on. So now let's talk about some of the other aspects that you need to be aware of for vascular surgery. Let's see here. I added this great little comic. It's kind of small. If you get this printout, you'd probably be able to see it. But it says, you can see the guy and he's got a cord out of his chest, and it says, oh, that's just a bonus feature. You can plug an iPhone into your chest. Your new pacemaker came with that. So I couldn't help but share that. And again, because everything you think of it being wired, vascular surgery is going to be talking about things like putting in pacemakers and putting in stents and stuff in the heart. Some of the vein treatments that you need to be aware of. So the reason I wanted to list these, a lot of people just think vascular means veins only, and it isn't. But I picked these 3 vein treatments so that you could go and use it as a launching point to do your own research. So we have RFA, which is radio frequency ablation. Then we have EVLT, endovenous laser treatment, and let's see, mechanical chemical ablation, MOCA. In the medical field, we abbreviate everything. We don't ever write any of these things down. So I wanted to also show you how some of that stuff is abbreviated. Use that again as a launching point to look at some of the vein treatments. That is just the tip of the iceberg. Then I found these scenarios that I wanted to give you to also help you think about the different things that you would come across if you were coding for both cardiology or interventional radiology and vascular surgery. So the first scenario is a patient presents to the ER with a cold leg and dusky forefoot. Previous FEMA pop with prosthetic, now occluded. Good caliber GSV, off to OR, meaning, okay, all of this points to that we have some type of a blockage going on. So the first thing that you'd be involved with is your cardiology provider is going to be doing a consult. Then you'll be coding for that femoral popliteal bypass with a vein. Then they'll probably do an endarterectomy at the side of the bypass, and then they'll do an angiogram. Then they might have to redo the bypass. We have a poor inflow with iliac occlusion, so they got to go put in an iliac stent. And we're not done. As we scroll down, we're going to see more. And again, this was all stuff that a provider who had listed that, just from that scenario that they'd probably be doing. Then you'd probably be following up 2 weeks later with a patient bypass, but had a TIA, which is a stroke, a transient ischemic stroke. US shows high-grade stenosis, so we've got a clinic visit. Now, a TIA doesn't last very long. It's like a little baby stroke. So then they got a CEA. Then you follow up a month later with the patient bypass, but gangrenous toes 1 through 5. So again, that forefoot was losing circulation, and it's gotten so bad now that we have gangrene set in. So you've got a clinic visit, you've got a TMA, and then 2 months from the original presentation, patient complains of pain in calf with ambulation. So we've got a duplex, reveals a drop in ABI, but stent poorly visualized. Angiogram then is going to be done, and they're going to show high-grade stenosis at distal anastomosis. So this was all work that's been progressively being done to save this fella's leg, right? And then the decision's made to intervene and treat with angioplasty. Then they throw out a couple codes. Angiogram of the aorta, then move catheter to look at the LLE, and then an angiogram of the aorta, pelvis, and LLE without moving to the catheter. And I hate it when they use WO for without, because it's really supposed to be /S. Anyway, and that again, just an overview of all of the things that you're going to be coming across with vascular surgery, interventional radiology, and cardiology, all of these terms. So if this seems foreign to you or exciting because you want to learn more, which I hope it's that, then it'll be a launching point for you to go and say, okay, I need to go look how angioplasties are done. What's the difference between an angioplasty and angiogram? What is an LLE? What is a TIA? What does it mean to describe somebody that's getting poor circulation to the extremities? What's the signs and symptoms? The common tests that are done. And again, I wanted to just kind of give this person an overview so that they could say, okay, now I know what I need to do to get into vascular surgery. And next thing you know, you'll be taking that CIRR, the CIRC, the CIRCC, interventional radiology credential.
Great.
Yep.
As always, thank you. Okay, we're ready for another poll here. What area do you feel you need more education in?
Vascular surgery, no.
Anything cardiology related?
We got billing, CPT, ICD, my favorite ICD, specialty credentials. Let us know in the chat box. And if you're watching us in YouTube, Facebook, or LinkedIn, make sure you put that in there. And also other, if there's something else that you need more, maybe it's compliance. We have some, or terminology and anatomy, like I mentioned before. I think everybody should take a course in compliance because it touches all avenues of coding, in my opinion.
And I think people are just finishing up here. We'll give a couple seconds here and then we'll shut the poll down.
Jennifer's really good at billing. I love ICD, but right now I'm educating myself in CPT, and boy, oh boy, it's not it's not easy to jump back in there when
I'm glad we don't have to test every year.
yeah. Oh wow, CPT.
Oh, wow.
Good. Billing,
Yeah.
28%. You know, wise, you guys, 39%, because most of the coding, the profi coding, the mainstream coding that people do, it's based out of CPT. And so you want to have a thorough knowledge. And like I said, I'm lacking in that and trying to build that up now. ICD, super fun stuff. So 10 for specialty and 10
Specialty,
for
we
other.
have inpatient coding, risk adjustment, compliance, documentation and auditing are some of those in the webinar one. I don't know what's in the
Good.
other, what we
Well,
have in the other
that's
ones.
great, because if you guys take some time at, this weekend to go look at cco.us, we have courses in every one of those. So you can check and see if that's the avenue you want to take. What do we get to do next? I suspect Jennifer gets to go next, because Boyd always
Probably.
sets us up every other one. Poor Boyd's really having to work hard tonight because one of us are usually driving and he's having to drive and do all of his other stuff. Okay.
Okay. So we had a question come in. If we have a patient who comes into the emergency room with a puncture wound from a fish hook being embedded in their finger, do we bill that with a CPT code, or is it best used with an E&M code? So I actually went in and I looked at some of this, and there was a website that I've quoted on here where I did get some information. But if you just Google it, you'd be surprised at how many questions are out there answered about a fish hook. So my one thing that my aunt has had a glass eye since she was about 7 because her brother threw the fish hook back and caught her in the eye, which I don't like dealing with those things. But a fish hook somewhere in your body actually happens pretty often, apparently. So one thing that we always have to look at is how it is documented. What does our documentation prove? So if it is not justifiable for a procedure or an E&M, even though one might have been done, we know they don't document very well sometimes. So we need to make sure it can be supported by that medical documentation, no matter which way you're going to bill. So if the documentation is medically necessary for a procedure, in addition to an E&M, perhaps there was something else going on. Maybe they slipped and fell and also fell on the fish hook. So now they've got a fish hook in their foot and possibly a sprained ankle or something like that. So we could possibly have multiple things going on. So we always want to make sure that medical documentation stands to support whatever is done. So like I said, I found so many things about this. The fish hook, they consider, of course, a foreign body. This is a foreign body now in your person. So foreign body removal has many, many codes out there to support a procedure for a foreign body. Different procedures, all dependent upon the body structure, all dependent upon where this foreign body is and how far this foreign body's in. You could have it in, just looking down some of the codes, you go to the index of your CPT and you say removal, foreign body. I think there's a column and a half or something of all different kinds of foreign body removals. It could be in the gum, muscle, eye, pharynx, toe, finger, you know, you got foreign bodies everywhere, of course. So they're all different codes depending upon the circumstances. But for the scenario we have, we can take a look and see what that would fall under. So we have 2 CPT codes in the integumentary system that would justify a foreign body removal of a fish hook. So this would be CPT 10120 and 10121, incision and removal of a foreign body, subcutaneous, simple or complicated. So it depends on what kind of situation we're looking at. But the key word in both of that is incision. So a provider could back thread it maybe out of the finger. Well, they're not really doing an incision then. That would be justifiable by an E&M. But if we had to, if they had to cut it either with the fish hook itself, could be used to cut through an incision, or if they had to use some kind of tool or instrument to incise or cut into the body part, then you're looking at an incision. So it depends on what's beneficial to the patient, what's less traumatic, maybe if you're dealing with a small child, what's less traumatic on them, and also looking at infections or other kind of complications that could come from that. So they, of course, make their medical judgment and depend upon what kind of, how they're going to take care of this foreign body. So if there's no incision, then we're going to look at an E&M. Now remember with all E&M coding, so if we want to move down a little bit, you always got to make sure you meet those components, whether they're 2 or 3, dependent upon the place of service you have, dependent upon a new or established, or you know what kind of qualifications we have here. So you always want to make sure you have those components, because like they could think that it's going to go under procedure, but if it didn't meet that qualification, we got to make sure that they justified enough HPI, exam, and medical decision making. So things that we look at in the surgical section, it says, remember, these things are included with the procedure. If it's not separately identifiable, that E&M has to be separately identifiable for another reason or based upon that medical decision making process. A local block or anesthetic. Maybe they need to numb up the area, perhaps. That's going to be part of our procedures. Immediate and typical postoperative care. Those are included with our procedures. Writing orders, medication, things like that. Those are part of it. So as this was in the finger, but there are foreign body codes indicating the rest of the body parts, or also the depth of that foreign body. How deep is that foreign body? In this case, we're talking about a fish hook, but of course, there are other things that could go much deeper. When you talk about the deep or complicated foreign body removals, because some of the descriptions will say deep, or some will say some kind of complication or complicated procedure, then those are described as including usually the fascia and or the muscle. So they're not superficial. We're talking much more involved process here. And remember, everything, I love to talk billing, everything is based upon relative value units. What is the amount of work that's going into that procedure? So of course, superficial, that's not a lot of work. Going down to the bone, that's a lot of work. So we need to make sure that that documentation justifies those procedure codes. Most of the information I've got originally about just this fish hook came from this Zootech Partners website. So, but then the rest, remember, we've got to make sure everything's documented properly. So it depends on what they did. If they did an incision, then you would have one of your simple or complicated 10120 codes, or an E&M, depends on how they removed that foreign body.
Thank you, ma'am.
And I know Alicia said
Yay.
growing up where she grew up, being an EMT, she saw a lot of Fishhooks in her
Yeah,
days.
it was a resort town on a big giant lake, Lake of the Ozarks, Missouri. Lots of fish hooks. Yeah. And
Yeah.
yeah, when I worked at the hospital, I was the Fishhook queen. I got to set up the tray for, so I loved it.
No, thank you.
Oh, you guys, now it's time for you to find out firsthand. Was that firsthand? I guess it'd be secondhand. What people are saying about, CCO. And, it's one thing for you to go do your research and stuff and maybe see ads saying, oh, we're so great and so on and so forth. And we are. Not that we're tooting our own horn. However, wherever you want to go get your education especially online where you're not going to be able to meet people face to face, really pay attention to their testimonies. All reputable sites will have them. And really thrilled Boyd keeps ours up to date, the latest that have just come in. And this one came in that was fabulous. This one just came in, yesterday? Or I think it was yesterday.
Mhm.
So I am proud to say what Melissa wrote to us. She said, I just found out I passed the CPC exam with an 84, which is really great. I don't
Awesome.
know how anyone could pass this exam without following CCO's proven process. The bat alone is worth it all. Thank you to your staff for your guidance in getting me prepared for the exam. Well, we had planned to talk about the bat because it was going to be, and we found it was in that article. And then she goes off and mentions the proven process. And this is like it's not a motto. What would that be called? This is what we're always talking about, the proven process.
Sure thing. I don't know.
Yeah, we got a
Yeah.
video on it. You go
Process.
see it.
It's our signature solution. Yeah,
There
that's
you
my
go.
There
marketing
you
term.
go. And part of that includes using the bat technique.
Yeah, and Alicia has a great video on that. So if you Google CCO proven process, you'll probably find the video, and certainly it's in YouTube. So that's the best way. I can't pull it up in our middle of our presentation, but
No.
that's the best way to learn about it. And we also have a big long blog post on CCO as well, cco.us as well. Great, thank you for that. And we're almost the second to last one, I believe, and we're doing great on time. So this one's all Alicia.
This one said, I was recently given the responsibility of coding wound care. I've never coded wound care and have to say I'm lost. The physician documents one thing in the body of the note, and the diagnosis codes most often do not match the documentation. The diagnosis codes are the original presenting problem. Do you have to carry that? Do you have to carry the diagnosis throughout the care and add the new diagnosis as the wound ulcer heals or gets worse, or do you just use the current diagnosis? Wow. I was really excited to see this come through because, as I mentioned before, I love diagnosis coding. It is so much fun because it's all about the disease process and stuff. But of course, I found another little comic. What this one says, well, we took care of that ulcer on your heel and the one on your bottom. I don't think you'll have any problems anymore. And you notice he's just ahead. And then the nurses are over there saying, I don't think I'd tell him about the ulcer on the back of his head. Anyway, I thought that was great. So yes, it is a problem, especially with wound care. Oh, it looks like the font. Oh, there it is. Okay, thought it cut off. A couple things that I wanted to mention. This gives me an opportunity to do like a little teaching moment on something besides just the diagnosis codes. So I didn't go off and find a bunch of diagnosis codes for you to be aware of because that's really not the question. The question is, how come I have a disconnect between what the provider's doing at the wound care clinic, a lot of times it's a wound care clinic or a wound care doc, compared to what they came in for or what the referral was for, etc. So why do we have this disconnect? And isn't it important that we've got the right diagnosis? A lot of times everybody thinks, well, it's more about the CPT code in outpatient, and it is. However, I mean, the CPT code is how we get paid, But you hear me say again and again, we code for statistical purposes. It just happens to be a convenient way to get paid. So one, we want to get the statistic right. We want to know how many ulcers or whatever we're getting in a given amount of time, how many diabetic ulcers versus other type of ulcers or wounds. And then we also want to make sure that we're coding for medical necessity. And the reason that is so important is that we have these things called LCDs and NCDs. When you have a Medicare patient, and Medicare is your largest payer out there, whatever Medicare does, just about everybody else ends up doing eventually. So Medicare works off of these local coverage determination, and the NCDs is national coverage determinations. Ultimately, what it means is they look at a diagnosis, okay, a disease, let's say a diabetic foot ulcer, and then they determine what treatments are the most effective and cost effective to fix that particular diagnosis. So that's what they'll cover. Okay, so if a new treatment comes out, it may not be covered. It may be a great treatment. However, if it hasn't gone through the LCD or the NCD, Medicare or the insurance company may say, well, yeah, it may be great, but we're not going to pay for it because it hasn't been proven or it's not cost effective to do this at this time. We have to do more research. So in the event, what that does is Medicare Part D may say no, and it's not based on medical necessity. So if you want to have it done, you're going to have to pay out of pocket. Now, for the most part, Medicare runs these. However, again, whatever Medicare does, usually the other providers follow, not providers, but the payers follow. But we remember medical necessity is the key. Is it medically necessary that this new treatment be used, like hyperbaric chamber, when we could just do a skin graft and let it heal slower, right?
Apparently it's
because that's proven work.
Part B, not Part D, Jennifer's
Oh,
saying.
okay. That actually came from, that's linked. So you guys, I copied that from an article. So the link is there in the footnote, and
Got it.
and we know Jennifer's right because Jennifer is a billing expert. Okay, so when they establish these policies for the particular item, it could be an illness or an injury, and they'll say this is covered, but this is not. Okay, and also LCDs could change for different areas. So let's say we're talking about Texas, where I'm at, versus Boston. I always like to give Boston as a, we probably have more diabetics, I'm just assuming, because of our nationalities that are living in Texas compared to the Upper East Coast, right? People with a Hispanic background are predisposed, and certain other ethnicities are predisposed to certain diagnoses. It's just part of the disease process. And so we have more of that ethnicity in our part of Texas. So maybe for their LCD, these specific treatments are approved, but they may not be approved in another area, like Jennifer's up by DC may not be approved there, but it is in Texas. Okay, so that's important to remember. So if you're a coder and you're working remote, okay, then you have to be aware that LCDs could be different. You may have a provider in one area that's these procedures can get paid for, and another one that's not. Also, again, it's not all about Medicare, just Medicare, but so that's like the third time I tell you they're the biggest payer. Why does it matter though? Actually, when you boil it all down, we need the diagnosis, make sure it's the right diagnosis to show medical necessity. So if the auditor is looking at the documentation and the coding, they're looking for medical necessity, and the diagnosis code gives us that. We definitely want to make sure that our patient fills out an ABN if they aren't going to, if it's something that's not going to be covered under an LCD, or your provider will be picking up the cost most likely to do the procedures. Now, I've got some great examples that I wanted to share with you to just kind of bring it down to practical things that you might see in a wound care clinic. And the number one thing is ulcers. So this first example is wound care diagnosis and treatment. So if a patient's discharged from the hospital with COPD, diabetes, peripheral vascular disease, neuropathy, and a foot ulcer, and is referred to Dr. Ichitozi, I came up with that, his wound care clinic. Now, what diagnosis is going to be the one that got the referral to the wound care clinic? It's not COPD, it's not diabetes, it's not the PVD, it's not the neuropathy, it's the foot ulcer. Now, the foot ulcer is the wound. That's what the patient's being seen for. Now, it's a diabetic foot ulcer. Is it important to document that in addition the patient has diabetic neuropathy, not diabetic heart, PVD, and they have COPD, so they don't have good oxygenation probably? All of that's important. But if you put that the patient's being seen because they have diabetes, that's incorrect. The medical necessity for a wound care clinic is not diabetes. It is not COPD or neuropathy or PVD. It's the foot ulcer, a diabetic foot ulcer. Okay. Then, as the foot ulcer is, it's staged. So each time that the patient comes in to be seen and the stage is getting lower and lower because it's healing, then that has to be changed. The diagnosis is going to change as the patient gets better or could get worse. We could have a small, diabetic foot ulcer that they're trying to get ahead of that ultimately turns into gangrene. And then we have necrosis, death of a tissue, and we're amputating toes. Okay. And then we're not treating a foot ulcer, we're treating gangrene, correct? So again, pay attention to the documentation, and if we have to educate or update, then we need to make sure we've got that documentation correctly, or you will not get paid in the wound care clinic. Let's give another one. Patient released from ER due to brown recluse spider bite on the left arm. Now, again, spider bites, please guys, they're not, in snake bites, they're not as bad as everybody thinks. It's not like in the movies. However, you don't even really get antivenom anymore, but they can go bad very quickly, and especially if you have comorbidities. So this is really, really bad. This is a spider bite. We got a brown recluse. It's 9 days after the bite is what the picture says. Now, ultimately, brown recluse, what it does is it softens the tissue so that they can eat whatever, and suck out the juices of their victim. And so it's like a necrosis that builds up. Now, this is not actually an ulcer. This is a wound, a gaping wound, and it probably is going to end up getting a graft. Again, how do they treat these? Usually, you can go and read, but they usually just treat the signs and symptoms. Actually, a black widow is much better to get a bite from a black widow because it doesn't get necrotic like that. It's actually works on the nervous system. It's very, very painful. But people that have bad immune systems or have other types of conditions that are already affecting the nervous system, like diabetes, it could be really, really bad. I'd rather get bit by a black widow than a brown recluse. So this just real quickly shows you, one is a neurotoxin and one's a cytotoxin in the venom. So two separate things. So the treatment would be different for each one. Okay. Now, why is the patient being seen? They're being seen in the wound care clinic for a wound. The spider bite is the external cause, right? It is a wound, the type of wound, and it'll be measured, the depth, and so on and so forth. So we want to make sure we get the diagnosis codes up to date each time. And then we have to check the LCDs to make sure they're covered. the treatment's covered. So again, I just had a couple more pictures and things to explain why it's important to code to the highest specificity and get those diagnosis codes right. And also LCDs are changing constantly. You may have to check like 6 times in a year. So whoever's in charge of that, especially if you're in a wound care clinic, you need somebody that's in charge of checking what's going to be paid for. This is actually a brown recluse, and it's a graft. You can't quite see it very well, but it's 38 days after the bite, and that's actually been grafted in. It looks like cheesecloth in there. So another thing that they do is this HBOT. I got to do a tour of a wound care extension of the hospital, and they have a oxygen hyperbaric treatment. And this is something you'll see as a treatment that may or may not be covered in a wound care clinic. Nowadays, I think you're seeing more. The place that in San Angelo, I think they had 2 chambers or 3 chambers at the time we toured, and they probably have more now, because it's very, very effective at healing quickly. Ultimately, what it is you're not putting oxygen in the bloodstream because if you're breathing it, that you're in a chamber, just like if you were to get the bins, divers in, and they infuse the tissue itself with oxygen, which allows it to heal faster. They not only use it for now certain spider bites, but certain wounds it's very effective on, and other things it's not. So medical necessity is very, very important. If you don't let them know what the origin of the wound is, oh, this guy's got a giant wound on his leg. Well, it's because it's a brown recluse spider bite, and it was neurotoxin or not cytotoxin, so we know that would be beneficial to put them in a hypobaric chamber versus a black widow, which wouldn't be because it's a neurotoxin and oxygen is not going to affect the nerves. It doesn't affect, you want the tissue itself. And again, I'm kind of paraphrasing and guessing at that because I'm not an expert in that. So take that with a grain of salt, which one you do and which one you don't. They are studying brain injuries now. That was that I linked that. But the thing about these HBOTs is it's painless, it's invisible, it's simple to do. And once you've paid for the machine itself, it's pretty cost effective. These are actually approved by Medicare. That means the LCDs, the NCDs are paying for it because it's cost effective. If you show medical necessity, which would be a diabetic foot wound, and sometimes burns will, again, we're infusing oxygen, and now they're studying for brain injuries and stuff for veterans that have had brain traumas. And it's looks like it's going to be very, very promising for them to be able to do that. This is what one looks like in a clinic. You can't have any makeup on. You have to like strip down and put on a gown because you can't have certain metals and stuff like that. Again, and it's a tube full of oxygen, intense oxygen that's pressurized, pushed into the skin. And so that's exactly what it looks like. They plug you in and you're not in, and it's not fast. You're in there for a couple hours, I think is the way it works. I've known one person personally that's done that to a wound on her ankle. So great stuff, very exciting. And I'm glad you're doing wound care. I thought it was pretty interesting, but it is a different type of coding because of these LCDs and stuff that you have to be on top of it constantly. Documentation is usually not the best that it can be because they're just taking stuff from discharge summaries and not getting the right code associated with the CPT code. And therefore, you'll have people, not only do you have wound care nurses and providers, but you have wound care coders. And so they're separate and sometimes do it exclusively because you got to stay on top of it or you don't get paid.
Over in YouTube, Susan asks, where do you check the LCDs?
Well, Jennifer can tell you because that's something that she has to deal with all the time.
I'll be happy to.
Yeah, let her explain that. She's much better at that than I am.
Well, the reason I had to interject is if anybody knows the structure of Medicare, Medicare Part A is hospital and rehab. Medicare Part B is physician. Medicare Part D, as in David, is your pharmacy
Drugs.
prescriptions.
Yeah,
So
isn't that
that's weird? Yeah, so that wouldn't have anything to do with your wound care. So
I wonder why that was in that article.
They just typo, probably didn't catch it. Yeah. The LCDs and the NCDs, if you go to your local MAC carrier, so in my area, we're Novitas Solutions. So I would plug in that website. You go to, they have, like ours, Novitas, you have a little sidebar that says LCD and NCD. And you click on that, you can plug in 29889 CPT code, and it will tell you if there is, you could plug in wound care and it will pull up all the NCDs, or it will do NCDs and LCDs. Because like Alicia said, you know, if you're a Wisconsin physician, your LCD might be totally different than mine, but a national coverage determination is nationwide, and every Medicare contractor will follow that one. But you could have different local ones depending on, you know, people in Florida have a whole lot more Medicare policies than somebody in Alaska possibly, or Montana. You know, there may not be as many Medicare patients available in that area with particular problems. So yeah.
It's exciting stuff. And you got to be on top of it. How often do you suggest they check them? I mean, if somebody's doing that, they got to, the thing had said like 4 to 6 times is what I heard.
They can adjust them. Right now, they are actually going through a big adjustment because they are transferring all the, because you know, you can go on there and it will say they need to have these medically, it is paid for these medically reasonable diagnoses. This is, you know, you need to do step A, B, C, and D before we're going to allow this, or you get 12 per year, or things like that is what they'll say in these LCDs and NCDs. But then it also gives you the updated. So if you, but however, you don't have to constantly go in and check as long as you belong to your MAC carrier's listserv, because when they change, they send it out in the part of the listserv email, and those go out 2 or 3 times a week. So as to any changes that have been made will be published in their listserv. They don't just willy-nilly do it because they feel like it. They let everybody know that there's been changes. So
Yeah.
So do the physicians look at LCDs?
they probably wouldn't even, they probably think it's a certain drug or something and wouldn't know what you're talking about.
Yeah, because it looks like NDCs. That's your drug.
Yeah.
No, that's honestly, that is your clinic manager, your coders, and so that's their responsibility. That's part of what you're being paid for. Now, don't freak out if you're going through your schooling and educating, you're thinking, wait a minute, I don't remember anybody talking about this. This is something that's real world, and it's just part of the policies and procedures in an office. Okay, it's not like you have to learn anything new. You're learning the codes, and then you just look, oh, nope, that code can't be used with that diagnosis. It's that simple, you know. It's a little technical,
and they're particular for the field that you're in too. Right. I don't know all the LCDs and NCDs. I only knew orthopedic ones. So whatever is going to be relevant to whatever field you're in. So.
Yeah, and if you're in risk adjustment, you don't care. Because you don't look at CP diagnosis code, or you only look at diagnosis codes and things like that. So, yeah, it's just a background thing that we do.
Awesome, thank you. Let's talk about the CCO club, guys. Why do people want to be here? I think I've got a poll. Let's find out. First of all, if I can find where my message is, because you guys have had me working so hard tonight.
Oh yeah, Boyd hasn't had to do this much in a while.
Gosh.
Not that he doesn't do a lot.
That's the word I'm looking for. Right.
And he's got all these computers to work.
He's all this stuff. He's streamlined everything that he does, and then we threw in all this other stuff. It says, are you a member of the CCO club? Yes. Or no, I decided not to join at this point, or no, didn't know about it, isn't important for my career. So while you're taking your poll, I'll just mention a few things about it. One of the perks that I like about the CCO club is that we do webinars during the week. Sometimes we've got a lot slated, but we do at least a minimum of 2 a week live. And so when they stream live, we do student webinars and club webinars, and sometimes we do webinars for disease processes and stuff. We call them pearls. But the thing is if you're in the club, you have access to those webinars afterwards. You get the slide deck, the printout. You get to go in and look at the questions associated. Maybe we're going to set it up for CEUs and everything. You have access to us to ask questions. You get primary, slot in us. You're first of the line to get your questions answered and stuff. But if you're not a part of the club and maybe you're watching us on LinkedIn or Facebook or YouTube, you may see us live. We'll stream it live because it's just a perk for us giving back that education to the community. However, it's going to get pulled down. It's a temporary thing. So if you don't watch it live, you don't get to see it. And the CCO club members get to see that. Now, on top of that, you get CEUs, and we maintain at least 80 in there all the time, and they're exciting, energetic ones.
56
They're fun.
was the current.
56, yeah. We kind of used to, we had like 200, and it was getting to where it wasn't cost effective, and we didn't want to raise prices, so we narrowed it down, kind of slimlined it, and even kind of put some packages together. So you're not going to get like a half CEU or a one CEU. No, we're going to give you 3, 5, 10 CEUs, and we're combining stuff together for you to meet. And again, it's fun and exciting, and it's applicable to what you're doing in your career. So it should never be dull. I think you got the impression we're not dull anyway. We're pretty passionate about what we do. No.
Yeah, it's pretty extensive here, and I'm only a quarter of the way
Yeah.
down the page. So there's a bunch of different levels that you can join at too. So from basic to full blown. So I do want to share the poll here to show that people, wow, that's interesting. It's like almost split 3 ways equally.
Wow,
That's interesting.
I've never seen that either. It's a nice night for firsts.
So why is it important for somebody's career? That's a good one maybe to answer.
Well, even if let's say you're getting your education someplace else, not at CCO, and maybe you got the blitz or you didn't get the blitz, but you need to be connected. You want to have a place where you can go in and ask questions of subject matter experts. And also, you're always going to have to maintain CEUs. It's a way of life for a professional, whether you're a policeman, whether you're a bus driver, whether you're a provider or a coder. You have to do this. Nurses have to do this, and so on.
X-ray
So
techs. Yeah, everybody.
X-ray, everybody, and so it's not always easy to find a place to get the CEUs, or maybe you're not so concerned about the CEUs. You want to know about wound care coding or LCDs, or something like I said. Jennifer specialized. She did orthopedics, and she also is our billing specialist. And personally, I'm not fond of billing, but you throw an ICD or a disease process question in front of me, and I'm going to go nuts. So we want to make sure that you have access to that in an affordable way, so you're not out there just jumping around trying to find information.
Doing what we do when we do research, we actually go through a lot of, we check a lot of sites, we make sure they're valid, we make sure people give a same consensus of information, and you may not have time to do that at your job. Oh, let me just Google it. Well, it may not be so easy just to Google something.
Don't trust Wikipedia.
So that we do have a lot of members who will say, okay, this person came in, what do you think? This is what I was going to build. Does that sound right? And they have a sounding board to kind of, because if I don't know, I might ask somebody who I do know. You give me a cardiology question, I don't know how to answer it, but I do know somebody who's excellent at it, and I will ask her. So, we do have resources, we do have things available to help you do your job more efficiently as well.
Yeah, whether you're a student, or we like to say, we want to train you. We want to code. We want to train you to pass the exam, give you all the tips, and then we want to keep you afterwards to help you with your education. You never know it all. Never know it all.
I don't know it all. No, I love to learn.
I'm working on trophy stuff right now, and my brain hurts at the end of the day. It's like, oh, all you family practice coders out there, God bless you.
I do.
do is we are actually got one more question, I believe, right?
It's pretty quick too. It's
Okay,
not
so
so bad. Yeah.
we will go for it. Let's
Yep.
go. Thank you guys for letting us talk about the club. And here's Jennifer with our
So
last one.
this kind of just came in. Somebody just posted it and says that they announced it artificial intelligence. Well, I picked up on it because I'm thinking what some people mean by this is, uh-oh, CMS is saying there's artificial intelligence out there. My job is going to be replaced, because we hear this quite often. We hear somebody say, oh, I was at some convention or some dinner or some function, and somebody said that, this is taking over. Well, so let's, before we all jump and start going, oh no, I'm losing my job, I better go learn something new, let's investigate what this is. So I just thought it'd be really interesting just to bring you some more information about it so people aren't freaking out when they hear Medicare is authorizing artificial intelligence. Well, the first thought is, yes, it's going to take over our job. We're not going to have a job, but we already do have computer assisted coding. And if you're somebody who uses computer assisted coding in your field or in your work, it's not always very good. I mean, it can do some things, but it can't pick up everything. And we all know from reading a medical record, we can understand that doctor's thought process, but he kind of forgot a few things. So if we have a computer reading that documentation, it's going to look a little bit different because we may have to do some of our own human interpretation in there. So someone still has to write the code for that computer assisted program. Maybe you can use your coding skills, and maybe you're a good little IT whiz. Somebody has to audit the chart. If the computer read that chart, you can't have another computer go back behind it and read it. It's going to come up with the same thing. So we still need humans to be able to audit those charts. And how are we going to teach these providers that they're doing it wrong after we audit it? We still need humans to be able to do that too. So a lot of things are not going to be replaced, even if this AI that we're talking about is going to come in and totally change medical coding. So will I take over? Well, AI, artificial intelligence. So another thought is that people are like, oh, it's going to, it's not going to take over. But right now, it should be there to help us. So we can work together with artificial intelligence. It can be used as a backup for our coding. Double check behind us. We talked about that back technique, making us a little bit quicker. Well, if we have a computer that can go over us, because how many of us have made mistakes? Is your job based upon your error rate, or maybe your pay level or something like that based upon error rates? Well, if you have a 5% error rate, that's kind of high. So if you have a computer that can go back behind you and double check things, that's what those scrubbers do when we send out our claims. In the claims payment process, a scrubber is looking at that going, no, wait a minute, you can't have those two things together. Okay, so don't worry about that either. We are human, we are going to make mistakes. So maybe having a computer along with us might not be so bad. But what this is talking about is something a little bit different. So there was a press release. So let's take a look at what it said. So we're going to, the CMS, Centers for Medicare and Medicaid Services, came out. Here's the link to their press release. So this came out October 31st. They had 25 participants out of 300 entries that they picked for a challenge brought about by this new government initiative brought out by President Trump. And I do have a link at the bottom that can bring you to more information about this AI initiative that the government is getting into. So, because there's other countries that use a lot more AI than we do, and they're a little bit more advanced. So we'd like to bring the United States up to par a little bit. So they're looking to aid clinicians in predicting health outcomes. How can we keep these patients healthy? If we know A, B, C, and D, then that equals E, right? So this is what we're looking at, using AI to read all this data, to interpret everything and aid the clinicians. So this is one of the reasons for it. The purpose was to increase the value. And if you've ever heard me talk about anything, this Patient Without Paperwork initiative is increasing the value. We went from PQRS to MIPS. So MIPS is all about cost, quality, providing value of care. So we want to increase that value and reduce patients' expenses, because, you know, they're getting a lot of things done. Are they getting better? Are we being beneficial in what we're doing? So we want to create quality care. So the challenge was to refine these algorithms, which pretty much everything's based upon math and computer numbers, and it all works together in some program. So they want to use the data sets that are currently out there with Medicare and try and find a program that can do that. And actually there was a monetary prize. So out of the 300 people who applied, or companies, corporations, and they're not just in healthcare, that put in for their idea, 25 have been selected. So that is the reason behind this news release. So if we go down a little bit more, so if that still doesn't kind of sound right to you, well, the challenge is, and this was a quote, is an opportunity for innovators to demonstrate their AI tools like deep learning or neural networks that can be used to predict unplanned hospital and skilled nursing facility admissions and adverse events. So they're trying to decrease the amount of hospital admissions and skilled nursing that people have. How can we decrease some of the expenses that are going from the insurance and from the patient? So they want to investigate these predictors and these different methodologies that can predict what's going to happen. So some of these solutions, these are just the titles, and I just thought they were pretty interesting. Leveraging AI to predict and improve health outcomes, maximize quality improvement, and reduce costs. Okay. AI for explainable adverse event prediction, empowering beneficiaries and providers to improve health outcomes. Okay, now we're working together. Now we're collaborating. We need the patients to tell us exactly what's going on and make sure the physicians are getting it. Using AI to improve Medicare population health. If you know anything about population health, smoking, cities of high chemical output, things like that, what's affecting the population and our health outcome? Optimizing ambulatory scheduling and reducing adverse events at hospitals. And another one was a human machine solution to enhance delivery of relationship-oriented care. I liked that one. I thought that sounded pretty cool. I mean, these are companies like 3M, Northrop Grumman. Some of these are some major companies that you went. Northrop Grumman, okay, they in my area, they produce all of our jet planes that fly overhead here next to my base. So, I mean, this is, now they're getting into the healthcare field, using all that knowledge that they have from some of their employees and bringing it to the healthcare field. So it's pretty interesting. If you want to know a little bit more about this AI government initiative that they have, I produced a link here as well. It gives a lot of information in there. A little bit more than this, it repeats some of the names of these papers that people presented. But I thought it was pretty interesting to think how we can grow in our healthcare field. Where are we going to? Now, remember that the U.S. Department of Labor statistics still says from 2014 to 2024, coders are going to double in size, okay? So it is still a growing field, and they're predicting it will be a growing field just from a couple years ago. So don't worry, we're not going to be replaced just yet. Not in my lifetime, I'm not looking at. So I just had a birthday last week. I still got a long ways to go. So
Happy birthday to you.
oh, thank you. I'm old. Just ask my kids.
And
Hey,
that is the last question for tonight.
did you launch
Thank
the
you,
new
everybody.
poll?
Yeah. Did you get value from tonight's CCO Q&A webinar? We want to know here. If you didn't, let us know in the comments how we could improve that. And stand by, we're going to announce our winner here in a second that we promised at the beginning of the webinar. Did you get value? Yes, no, or I'm not sure. Those are the options. And I'm going to close it. I think we're at almost 80% here, so just about to close it down.
While he's getting ready to close it down, if you're visiting us on one of those other social medias, Facebook, YouTube, or LinkedIn, don't forget to like and subscribe. You can share comments and let other people know about CCO if this was valuable to you. Wow.
Yay.
Great. So yes, absolutely. That 3%, let us know what you think would make this better. And we are all ears. Well, not all ears.
Thank you for that.
I'm partly hair. Look at all my good hair.
So let's see. We have a winner here. That's a survey. I'll share that link if you want to take a survey and let us know a little bit more. But our winner here tonight of either a Blitz video package or 1 year CCO Club Basic or a 1 hour session with Alicia or Jennifer or someone from the team is, I just had it right here and I just lost it. There it is. Rosemary Aguero is our winner here
Aguero,
today.
Rosemary. Congratulations, Rosemary.
Hey.
Everybody give her a golf clap. Yay.
Hey.
So what you're going to
And,
do is you're going to send a message into helpdesk@cco.us. Let them know that you're the winner. Of course, the girls at the help desk already know your name, so they'll be expecting your email, but that'll give them the contact information. You can let them know what you pick, or if you need some help picking something, maybe it's one of the Blitz videos, we can counsel you on that as well.
yeah, awesome.
Oh, and she says wow. She's
Good.
excited.
Great. Great. Okay, so, and I have to update this slide. I just found out that we don't have 80, we have 56 now. So I'm glad for that. And we're ready for some chat questions. So the webinar is officially over. And if you need to go, this is the good time to go. We've officially now ended up the prepared content. So some of you have had some questions in the background while we've been doing the webinar, and our team with Sylvia and Lori have put that together. So let's take a look at what we got here, gals.
Yay, the magic questions.
And the first one is about polyps, it looks like.
We got some webinars on polyps.
Let's see here. I need clarifications about when you can snare removal and cold biopsy removal be coded at the same section. For example, provider found 2 polyps and one was removed by cold and the other by snare. Both polyps extract from the transverse colon. About when you can, I thought you can bill both of them.
Yeah, you can. The codes, I think I know what they're talking about, because there is a code. Every time you take a polyp, there's 2 things that they want to know. They want to know how they took it and where it was located at. Okay. And so the codes that they've given, and just off the top of my head, you know, the 45380, I think, is the snare, and the 45385, or the other way around. One, but
I don't have my book next to me.
you don't have to. You should be able to code both of them for the transverse colon. I'm trying to think if there's anything that tells you that you.
That's what I thought it was. 45380 is colonoscopy code. Because I was just doing some auditing. I'm doing a big audit right now. Most of them are anesthesia colonoscopies. So colonoscopy flexible with biopsy, single or multiple, is 45380.
Okay. So
And
that would do your multiple pulls of the.
Is colonoscopy flexible with removal of tumor, polyp, or other lesions by snare.
Oh.
Okay, so you can't bill both together. They're both a colonoscopy. So you can't bill both codes together. But whether one was, what was the first one again?
Cold.
No, this is removal of tumor, polyps by snare. And 45380 is colonoscopy flexible with biopsy.
Now, biopsy is different than removing a biopsy. They're actually taking tissue, not. Now, will they biopsy the polyp? Yes. But if there's no polyps, you still can do a biopsy. You know, don't think that they can't.
So isn't it we're coding to the most complicated procedure then? Yes, so 45385.
So now another thing, now don't think of it as money. Don't think of it that way. However, more complicated will pay out more. So whichever one pays out more is probably
'Cause
more
it's
complicated. You can double check it, and that's
Yeah.
what you would code out to the highest.
because the RVU would be based upon the work, so it's more work typically for your higher, more complicated procedures. So that will pay more because more work was involved.
Now,
So
another little tip that we covered some time ago too, and I know this comes up that I'll just mention, is that also if they go in and do a colonoscopy and they intend to go up to a certain extent and for whatever reason they can't, you
mhm,
remember you code for the intent
mhm.
and then you put a modifier on there to say
Modifier.
why you couldn't get there.
53, 52, 53. Yeah, off the
52,
top of my head, I can't remember.
So always think about, and that carries over for other things too. It's the intent where they plan to go or do what they plan to do, and then the modifier will deduct part of that fee instead of coding to just the transverse colon because you couldn't get all the way up,
Mhm.
then you again, because they're going to it's not that it pays out more, it's just the fact that you want them to know the intent. It's the statistic that we need to know.
Mhm.
What medical necessity may not be going to the transverse colon. If they think that they've got some type of an ulcer going at the the all the way up by the
CPT.
duodenum, they want to go all the way up, and for whatever reason, if they can't and they have to stop at the transverse colon, it's like, well, what's the medical necessity for doing the colonoscopy just to the transverse colon when we have something wrong with the duodenum? Why didn't you just scope them and go down the other way, or whatever?
Mhm.
Diverticulitis. That was a
Yeah.
good one. Next. You drop an
Advanced care code. Can you drop an advanced care code without the E&M code?
I'm sorry, what's an advanced care code?
I don't think you can, because advanced care codes are E&M codes. I think. I won't be able to search
I
on
mean,
my
I'm not
computer.
thinking critical care. I'm thinking, what is
Advanced care are they talking about preventative?
99497, advanced care planning?
Yeah,
Okay.
like
Including,
not preventative medicine, but
yeah, including the explanation and discussion of advanced directives, such as your standard forms, provided by the professional or other qualified healthcare professional.
well, you wouldn't
So-
have a visit just to do that.
And I know it's something that they always ask. Do you have your, what is it? Your directive.
Advanced directive.
Yeah. But that is actually a MIPS character. Do you have your advanced directive? They need to see, they're checking the statistics of how many of these people have actually planned this out. So that's actually a MIPS characteristic. So the actual code of 99497 is first 30 minutes of a minimum of 16 minutes to be held with advanced care planning, which is face-to-face with a patient, family member, or surrogate to explain and discuss these directives.
But you wouldn't have that just by itself. There has to be a visit to begin with.
Should not be reported the same as critical care, neonatal, pediatric, by any critical care. You cannot do the same. Includes discussion provided. I would assume
You could do it with
that
annual
yeah.
wellness visit. Couldn't you?
No, I'm going to assume that this
That's
would
still an
be
E&M code.
Yeah, but I would assume you can do an E&M along with a wellness as well, because you're doing two
Yes, yeah.
separate things. So if you're doing an advanced care directive,
But-
specifically documented at least 16 minutes up to 30 with who you were with, what you talked about, what you went over. It has to be the same as we do with those counseling, with the counseling codes that are add-on for E&Ms. You have
But
to
you
have
can't
enough
do it without the
documentation.
E&M, I don't think, can you?
No,
I-
I don't think
I
it
don't
is
think you
billed
can.
separately. No,
There
this is
has to be
something
a
you're
reason for
doing
you to be there,
in
and that's
addition
on top of it.
Yeah.
Could
Yeah.
you say it's not a parent code? It can't stand alone. It's not an add-on code.
It's not
but
an
it
add-on
can't
code,
by itself.
but I wouldn't see why somebody would go to their family doctor or somebody just to only specifically speak about directives. Maybe they were,
That's right.
single, don't have anybody around, and now their daughter's coming in town and they want to bring their daughter in, maybe, but I don't see that scenario happening very often. So
Well, first of all, it probably doesn't pay out, so the doctor isn't going to.
probably doesn't
Why
want to
would
spend the time. Yeah.
he needs to see sick people, not
Yeah.
counsel on those. He'd say, go check with your lawyer. Yes, I don't know. Hypertension. When can you code hypertension, hypertensive urgency, hypertensive emergency, hypertensive crisis by the documentation? Like, what blood pressure readings constitute the different terms or the signs and symptoms that would accompany these hypertensions? Okay, first of all, you cannot code off of blood pressure readings or the signs and symptoms and call it that. It has to be stated: hypertensive urgency, hypertensive crisis. Those are key words. If they're not documented, you can't pull those codes. Simple as that.
So you code them because the provider said the patient was in hypertensive crisis. And that's what he's saying in his medical records. So then you can code hypertension crisis, which is I-60. I just taught my classes last night. I wanted to see if it could come up off the top of my head, but I can't remember.
Well,
I-63,
and the other
I
thing
think.
is these are not going to happen in the doctor's office. And if they are, you're on your way to the ER. So, so they should not be just thrown around as codes that you would normally code. These are emergencies.
And I
so-
believe I don't have my ICD-10 in front of me. I believe these have coding guidelines.
Oh, yeah, they do.
There are coding guguidelines for these hypertensives. So you have
Yeah.
to go exactly what those coding guidelines say in order to
It
bill them.
reminds me of the cancer codes. You know how the other day there was a provider that had coded that it was an ENT and he was going to take something off of the mouth, and it was a myelocele, he said, but he coded it as a neoplasm of uncertain behavior. Well, it's not that, but he didn't know that, because it's a myelocele actually has a code, and it was a cyst type thing. And so again, because those cancer codes have specific guidelines to be able to use them. And it's the same thing here. You've got to have that document, that verbiage, or you can't pull those codes. And we can't pick them even if we knew what a blood pressure was for one of those and the signs and symptoms associated to it. You can't do it. In fact, you can't even query about it. That would be
Leading.
doctor.
Yeah.
Yeah. You may know. And you know what's really interesting is when you start learning the disease process, and that's good that you do know. Don't think that you don't, it's none of your business, because you want to know. You want to say, oh, this is what I'm going to expect to see. These are what medicines he's going to take. And now I can look to see if he's going to be on anticoagulants or blah, blah, blah. Discharge summary, but
Billing
does
for
not see the
discharge.
patient.
It's funny, I just went over my book today for some reason, pulling things out. And I have this written next to the E&M of discharge. What did it say?
And?
What did it say now? I don't remember. I remember I wrote a little notation next to it that, okay, now why didn't they see him?
I was just going to say, I
Because
don't think
they planned it. Now, if they planned, say something went wrong, and so they're not going to be discharged till the next day, you can only bill discharge once. So is this discharge and the nurse is discharging them? Well, you can't bill for that. So you can only bill a discharge if the provider sees them. So because they have to discharge the patient. But if like something happened and they didn't discharge them to the next day, you actually bill the discharge on the day that they are discharged. Is what I am remembering I wrote in the sidelines of my E&M.
If they're going to discharge them, it's 10 o'clock, and by the time they get their paperwork and all this stuff, it's 12:15, and they're officially discharged at 12:15, which would make it the next day.
Next day.
That's
the day. Yeah. Yeah.
Don't do that.
I don't think they ever do it
I'm
overnight.
sure it does. But but that
I
there isn't
can't
any
remember
reason why, because they've got to do a discharge summary. They have to physically see them and do like an exam. Part of the discharge summary is an exam, isn't it? I mean, it's set up just like a you know, you're coming in, you're let out the same way. You got to have, you know, an
Mhm.
HPI, you have to have the exam review systems, all that stuff has to be in there. And
Yeah.
I think you'd be hard pressed to be able to do that.
So I'd say
Don't do
no.
it.
Yeah, don't bill it. Documentation. We have to have documentation.
That's it.
Oh, okay.
Take
So
us home
guys,
there, Alicia.
just like I've said more than once, if you are visiting us on YouTube or Facebook or now LinkedIn, it's kind of fun that they're doing these live streams now, then absolutely come like and subscribe. But our YouTube channel is Medical Coding Cert. There is lots of videos in there. We have over almost 1,500 videos. We've got lots and lots of subscribers, almost 4 million views. And this type of content that you've seen tonight cut up into smaller aspects, and you can go in and do a search. So if you're used to YouTube, you get on Medical Coding Cert and you want to get more information about LCDs, all you type in that little search is LCD, and it'll bring up, you know, 10 videos on it. If you want to, like, how to code a STEMI, STM, you know, we got them on that, vascular surgery, things like that. So or testing tips, things, you know, you can find that. You can do that. Facebook, a little different in that they don't have that search option, but Facebook, who doesn't like Facebook? You can get in there and be a part of education. Lori's always posting words of the day or week. I can't remember how often she does it, and conversations on people helping each other with testing tips or what worked for them, and it's a lot of fun. So make sure
And
you
we have
go in
more
and
than
you
one
like us.
group, right? We've got a couple of
Oh
groups.
yeah,
So
you have multiple Facebook groups. So yeah,
keep that in mind.
Mhm.
Local presentations, always for AAPC chapters. Little disappointment last week, couldn't make it to one, but
I was going to Johnson City, Tennessee. I've been there before and couldn't get the flight out at the last minute. Worked really hard to try to get there. So Sharon Oliver, I sent her the presentation, and she did it for the group, and they had like 100 people there, and they said it went over really, really well. But if you want a presentation, we have lots of remote presentations that you can pick from, or if there's a topic you'd like for us to do. The newest one we've done is the 2020 ICD updates, and so if that's something you think you would like to have for your chapter, send a message in to the CCO.US remote presentations, and L'Oreal will work that out. We don't have to be there. They're already approved for AAPC and AHEMA for CEUs. I think there's 3 on that one. It's almost 3 hours. But again, these are some of the topics we've had for a while, and we like to have a picture. We like to travel. We'll be traveling a little bit less till after the new year probably, but let us know if you want us to come.
yep. And the survey link again, and a little bit about the club. We're right at 10 o'clock, so I won't stop us from going home. And I think I put some extra slides in here. Yep, this is the real, this got bigger since the last time. Somehow these didn't get deleted, but anyway.
Yeah,
So let's go
CCO.
to the end. Let's go to the end. You also have a handout which has all the links that were discussed, all of the links that were discussed in the answer sheets. If you want a full copy of the answer sheets, those are still available in the CCO club, if I remember correctly. And we do
There's that
put up
testimony
this.
pages on there and stuff, so make sure
Yep.
you take advantage of doing research.
And don't forget about the Black Friday sale that's going on for another week here. So 40% off selected courses and blitzes. So take advantage. All right. So I think that's it from here. The team from us. I'm not sure if we're doing a webinar in December.
We haven't decided. We were going to
we
ask
were
you
talking
guys.
about that today.
Mhm.
We
Thought
didn't
we
have
did.
time for a poll, but we'll definitely be back in January. So no matter what, we'll see you in January. Put it that way, in 2020. Love saying that.
Bye, guys.
All right. Thank you, Alicia
Have a
and Jennifer. Thank you for all the time you guys put together doing this for us. Thank you for all the people who came for the first time. We love having you. New blood here always is great. Thank you for the old timers as well who have been here, being our rock stars, and making a great place to hear for us to work and share more of our content with you. All right. Until we
Bye-bye.
meet again.